Uh, thank you, Muhammad, for the invitation, and thank you for the introduction. Can you see my screen?
دكتور زياد
Yeah.
تفضل.
Okay. Can you see my screen?
Yes.
Okay. So it's a pleasure to be with you today. I'm going to talk about minimally invasive glaucoma surgery, and most specifically excisional goniotomy using the Kahook dual blade. So those are my financial disclosures. I always like to show this slide when I talk about MIGS. This is a figure taken from paper from Ramuru's team at Johns Hopkins. They basically plotted the number of glaucoma surgeries, the number of trabeculectomies performed in the US during the approximately 2 decades. And as you can see, the number of trabeculectomy performed under Medicare have been steadily decreasing between 94 till 2014. This is mainly due to a lot of factors like the introduction of new techniques, new medication, but it's also due to the limitation of traditional glaucoma surgery. As you can see here, trabeculectomy has a wide variability of outcomes. Even in the most experienced hands, you cannot 100% predict the outcomes of trabeculectomy. It depends on so many preoperative factors like the patient age, the type of glaucoma, the preoperative intraocular pressure, etc. Also, trabeculectomy needs a very intense follow-up. You cannot just do the surgery and see a patient after a week or after a month. The TBT study have shown that approximately 70% of the trabeculectomy patient needed a postoperative intervention like AC reformation, suture lysis, needling, or injection. And last but not least, trabeculectomy comes with a high rate of complication. The safety profile is not the best, and the complication rate has been reported to be somewhere between 35 to 50%, according to major glaucoma trials like SIGITS, AGITS, or even TBT. And you know that many areas of medicine are shifting towards what we call minimally invasive surgery, and ophthalmology and glaucoma are no different to this trend. And you hear a lot lately about minimally invasive glaucoma surgery, known by the acronym MIGS, and this topic has become a really hot subject during the last decade or so. So MIGS encompass a group of procedures that share some common features. They usually adopt an ab internal approach. So we go through a small 1 or 2 millimeter corneal incision. They are minimally traumatic with minimal manipulation of tissues, which leads to a very good safety profile, a rapid recovery with little downtime to the patient, and minimal impact on the quality of life. So if we put all glaucoma treatments on one big continuum, and if we plot them according to the efficacy in terms of IOP lowering and the risk level, you have basically two extremes. You have at one extreme traditional glaucoma surgery like trabeculectomy and glaucoma drainage devices. They have extremely high efficacy in terms of IOP lowering, but with a high risk of complications. And you have at the other end of the spectrum, you have medication, very modest efficacy in terms of IOP lowering, but that are extremely safe. Well, the MIGS procedure covers a wide spectrum of outcomes and procedures. They all share in common a very safe complication profile, but they have a wide variety of efficacy in terms of IOP lowering. So not all MIGS have been created equal, and we usually classify them depending on the anatomical pathway or anatomical structure that is being targeted by the MIGS procedure. So you have MIGS targeting the subconjunctival space, like the Zen or the Presiflow. You have MIGS targeting Schlemm's canal or the trabeculum, like the iStent, the Hydrus, the KDB or the Omni recently, and you have MIGS targeting the suprachoroidal space, like the CyPass that's not available anymore, the iStent Supra or the StarFlow. So as you know, we've always been taught that the main area of resistance to outflow is the trabecular meshwork, and the trabecular meshwork becomes abnormal in patients with POAG, and it induces an increased resistance to the outflow of aqueous humor, leading to a high intraocular pressure. And basically, this trabeculum is the interface between the anterior chamber, where the aqueous humor is, and the Schlemm's canal. And just by passing through the trabecular meshwork, the aqueous humor then has access to different collectors channels, and therefore to the episcleral venous pressure. And this is what we call the trabecular outflow pathway. So the trabecular meshwork is a very important structure in the pathophysiology of glaucoma. And I want you to remember here that you have not only one collector channel, but you have many collectors channels. And the concentration of collectors channel is the highest in the nasal angle. So I'm going to talk today about what we call excisional goniotomy, and about this tool that is the Kahook dual blade, that is one of my favorite MIGS devices that I've been using since 2016. It has a very interesting design, as you can see. It consists of a very sharp tip that allows you to pierce through the trabecular meshwork. It has a ramp that will lift the trabecular meshwork once you pierce it, and a dual blade system. So you don't have, you have two blades, not only one blade, but two blades that will allow you to do two incision in the trabecular meshwork. And this will allow you to do what we call an excisional goniotomy. So as you can see here, you have the tip that pierces the trabecular meshwork. You have the ramp that's going to put the trabecular meshwork under tension, and you have the dual blade system. So this is interesting because by doing two incision, you can excise a whole strip of trabecular meshwork. You can see here that we put the Kahook in Schlemm's canal, and it slides basically like butter through Schlemm's canal, and it allows us to do an excision of a strip of a band of trabecular meshwork. With traditional goniotomy, we use an MVR blade or any type of blade. And the problem with that technique is that you cannot control the depth of your incision. So you end up sometimes cutting through sclera, and you also leave two leaflets of trabeculum. And all this leads to inflammation and scarring. And this is why goniotomy is not quite successful, and it doesn't have very high success rates in adults. The difference with the Kahook dual blade is that you have a plate, a posterior foot plate that is blunt, so you don't cut through sclera. And since you have the dual blade system, you're left with minimal tissue behind you because you excise a strip of trabeculum, so you're not left with leaflets. And this reduces dramatically the rate of fibrosis, and it increases the success rate. So I'm showing you here a video courtesy of my colleague and friend, Paul Singh, and you can see how he performs the excisional goniotomy. He goes to the far right, and he goes forehand, excising from left to right, then he stops in the middle, and then he goes backhand from in the opposite direction from left to right, and he ends up having a strip of trabecular meshwork that is excised. And this is quite rewarding because you can actually see what you're doing because you're removing a strip, which is not very common in glaucoma procedures, especially in MIGS where you're working blindly. Here, you can see the outcome, the anatomical outcome of your procedure. And this is actually quite satisfying. So I'm going to show you two cases, two examples that I did in Beirut. So this is a case of phaco KDB in a patient that has pseudoexfoliation. You can see the classical target shape pattern on the anterior capsule, and you have a pristine view of the angle, a perfect view of the angle, the Sampaolesi line, and the pigmented trabecular meshwork that is quite characteristic. This is quite characteristic of a patient with pseudoexfoliation. And here I go with my KDB blade, my Kahook dual blade. And as you can see, I have to tilt it 10 degrees to be able to pierce in the trabeculum. And once I pierce the trabeculum, I flatten my foot plate on the back wall of Schlemm, and I just slide the KDB in Schlemm's canal, excising a strip of trabecular meshwork. And what you can see here, the whitish reflection is the back wall of Schlemm's canal. I removed the pigmented trabeculum, opening up the pathway from the anterior chamber to the collectus channels. I don't know why the video stopped here. So let me exit it. Are you still seeing the video?
Sure. Yeah.
Okay, so what I wanted to show you is once we do the excision, I don't know why the video is blocking. So I'm gonna go back to this view, hoping that you're gonna be able to see it here. So you see the pearly white reflection of Schlemm's canal. So you see that here, the pearly white refraction of the back wall of Schlemm's canal, indicating that I'm in the correct anatomical pathway. And you can see here floating the strip of trabecular meshwork that I managed to excise. And the interesting thing is that you have blood reflux at the end of the case, not only from one collector's channel, but from different collector's channel, indicating that you not only targeted one collector channel, but multiple collectors channel. And this is going to increase your success rate and the efficacy of the procedure. This is another case of phaco KDB in a patient with angle closure glaucoma. Unfortunately here, the cornea is not the best and the angle is completely zipped. So you do not see the anatomical landmarks of the angle under direct gonioscopic view. So I go in with my viscoelastic cannula, injecting slowly viscoelastic in the angle to dissect the syneculitis to free the trabeculum, opening up the angle. And as you can see here, by doing so, you manage to identify where the trabecular meshwork is. But this is not enough because this trabeculum is not functional. It has been fibrosed by long-standing angle closure. So I need to go in with the Kahook dual blade to excise this sick trabeculum, exposing the back wall of Schlemm's canal. And this has become my procedure of choice in angle closure glaucoma. So this is not an experimental technique. It has been around for quite so many years, and there are a lot of reports out there in the literature describing the outcomes of excisional goniotomy. And the median IOP reduction with excisional goniotomy with the KDB is around 4.5 millimeters of mercury, with a good reduction in the number of glaucoma meds. The landmark paper was published in ophthalmology glaucoma by Kahook and his colleagues on around 200 eyes. And the results of excisional goniotomy were sustained up to 1 year in the follow-up in this paper, with an average IOP reduction of around 20%. And also when they did the post-hoc analysis, they have reported that the reduction of IOP when the KDB was performed as a standalone procedure was around 30%, which is quite impressive for a MIGS procedure. The important aspect of this technique is that it's very versatile. You can perform it at different stages of glaucoma, not only early or moderate glaucoma, but also in some patients with severe glaucoma or advanced cases. And it has been reported by Mansouri and colleagues in the Journal of Glaucoma a couple of years ago, that in those patients, in this population subtype, they managed to obtain an IOP reduction of 4.4 millimeters of mercury at 6 months. And we know in advanced glaucoma how every millimeter of mercury counts to prevent and limit the progression of the disease. And approximately 2/3 of the patients got a reduction of IOP of more than 20% following those procedures. So you can perform the procedure not only in early glaucoma, but at different stages of glaucoma, but not only in open angle glaucoma, but also in different subtypes of glaucoma. And you can see this paper from Dorairaj from Mayo Clinic reporting the outcome of phaco, goniosinicolysis, and KDB in patients with angle closure glaucoma. And the results here are extremely impressive. You can see on average a reduction of IOP of 12 millimeters of mercury in those patients, with a very good reduction in the number of glaucoma meds. Around 2 glaucoma meds on average were reduced in those patients. So how does excisional goniotomy compare to other MIGS procedure? We all know the ancestor or the pioneer of MIGS is the iStent. You have the iStent G1 and the iStent G2. This is basically the smallest implantable device in the human body, and it has been around for quite some time. And when comparing the excisional goniotomy to the iStent, it's basically more or less the same technique. You go in with the iStent under direct gonioscopic view, and you implant the stents in the angle. So you implant the bypass in the trabecular meshwork in the Schlemm's canal, creating a communication between the anterior chamber and the collector's channel. But the problem with the iStent is that you're putting the implant at one specific location of the angle. So your chances of hitting the collector's channel are a little bit less than with excisional goniotomy. Even if you put 2 iStents, you're still at a disadvantage, because with excisional goniotomy, you're basically covering a wide portion of the angle. This is going to increase your risk of hitting not only one, but many collector's channel, which might increase the efficacy of your procedure. And if you look at the literature comparing phaco KDB to phaco iStent, you can see that in terms of IOP reduction in millimeters of mercury, in all those papers, phaco KDB offered an IOP reduction that was substantially higher to phaco iStent. And this was also true when KDB was performed as standalone versus iStent G2 as a standalone. So one might say, or one might think that, you know, all those paper, all this data comes from population that is different from the population we're seeing here in the Middle East. And those results do not apply to the type of glaucomas and population that we have here in the region. And this is why we started our own study, collecting our own data here in Beirut. So those are the first 58 patients we did back in when we started adopting this technique. And those patients cover a wide spectrum of glaucoma, not only open angle glaucoma, but secondary open angle glaucoma, angle closure glaucoma, and different stages of glaucoma. You can see that approximately 40% of the patient had severe glaucoma. And those are the outcomes at 1 year following phaco KDB. In this patient population, we have an IOP reduction of around 27%, going from 18 millimeters, 19 millimeters at baseline to 13.7 at 1 year. And this also happened with a very good reduction in the number of glaucoma meds. And usually the patients are quite happy with this aspect of the outcome. And by comparing our results to the literature, we can see that our reduction of IOP and our reduction in glaucoma med is in the range that was reported in other types of population, and it was slightly on the higher end. So in conclusion, this is a technique that has a very good efficacy, a very good also safety profile. The advantage is that you don't leave any hardware behind, you don't leave any implant, and it can be done as a standalone or in conjunction with cataract surgery, and it's extremely versatile. So it's not only limited to early glaucoma, but you can also perform it at different stages of glaucoma and different types of glaucoma. If you want to learn more about this technique, there's an interview that I gave with my friend and colleague Kaveh Mansouri in the October issue of The Ophthalmologist. You can read this interview where we talk about the KDB and the KDB Glide. This interview is accessible online. You can also scan this QR code that gives you direct access to this featured paper. Thanks again for the invitation. It's always a pleasure to be with you. And if there are some questions, I think we can take them now.
شكرا ألف شكر دكتور زياد. تفضل.
Thank you, Dr. Ziad, for this lecture. Can you hear me, sir?
Yes, I hear you perfectly.
Yes, I understand from your lecture that you do KDP in any age, and you do it in mild glaucoma, advanced glaucoma, you even do it with cataract. So when do you know that this procedure will not work preoperative? You say this, I will not do it because it will not work. And if it is having this high success rate and you do it at any age and at any glaucoma stages, why it's not the first line of treatment?
Well, we all know that in glaucoma, you don't have one procedure that will fit all your patients. For example, the gold standard is still trabeculectomy. Trabeculectomy is still the gold standard when it comes to glaucoma procedure, but you will not perform trabeculectomy in all your glaucoma patients because you have some glaucoma subtypes where it's not going to work. You have some patients where you don't want to do a trabeculectomy where you can reach a target pressure with a minimally invasive glaucoma surgery that is safer for your patient. So this has become my procedure of choice in many instances for many patients where I don't need a very low target intraocular pressure in patients with, for example, who already have glaucoma, who are well controlled with drops and who are undergoing cataract surgery. It allows me to reduce their number of glaucoma meds. Patients who have a borderline intraocular pressure where I just need a little bit of push to reach my target IOP, this is my procedure of choice. Angle closure glaucoma, it works wonders. My experience with this technique in other types of glaucoma like congenital is not that good. Juvenile glaucoma, it's, I would say, a 50-50 type of impression that I have so far, and the data is not that conclusive in the literature. I don't do it in neovascular glaucoma, for example. This is definitely a type of glaucoma subtypes where I don't do it, but it definitely has a lot of indication in my practice. And when you have a glaucoma practice, the more tool you have, the better you'll be able to manage the patient. So it was definitely a game changer in my practice. So I can offer this either before glaucoma surgery, instead of glaucoma surgery, or after glaucoma surgery in patient who, for example, had a tube 3 or 5 years ago when I need a little bit of additional IOP reduction. I've done in some patient, I've done KDB, or even patient who already had a trabeculectomy.
Doctor, how many times can you repeat this procedure in one eye?
I typically only do it once because usually when you perform MIGS in the nasal angle, once you excise the trabeculum in the nasal angle, if it didn't work, there's no point in doing it in another sector because usually the nasal angle has the highest concentration of collectus channels. So if it didn't work in the nasal angle, chances are it's not going to work in other sectors. And also technically performing angle surgery in the inferior or superior or temporal angle are extremely challenging. So I would only do it once, basically.
شكرا دكتور زياد. شكرا.
Thank you.
على الدعم. اهلا وسهلا فيك وانتظر دائما دعمك.
Thank you. Thanks again, Muhammad, for the invitation, and and hope to see you soon, inshallah.
Now we will be with Dr. Noha Al-Fayoumi, Head of Glaucoma Department, Ibn al-Nafis Ophthalmic Hospital in Damascus, Syria. The lecture is about cataract and glaucoma combined surgery. تفضلي دكتورة.